Exercise places an extraordinary demand on the cardiopulmonary system. Oxygen delivery must increase several folds to meet metabolic needs. This is accomplished through increased cardiac output, enhanced pulmonary diffusion capacity, improved ventilation, perfusion matching, and augmented oxygen extraction at the tissue level. Failure of any one of these adaptations can limit exercise tolerance and reveal underlying cardiopulmonary disease. During exercise, cardiac output increases substantially, which reduces pulmonary capillary transit time. Decreased transit time, remember, it makes it so that the lungs have to do that exchange, that equilibrium a little faster. Despite this, though, oxygen equilibrium remains complete due to increased diffusing capacity and recruitment of previously underperfused capillaries. Improved VQ matching ensures efficient gas exchange even under high flow conditions. In a healthy person, this physiologic reverse prevents arterial desaturation during exercise. Oxygen delivery to tissues depends on both blood flow and arterial oxygen content. Even with normal oxygen saturation, inadequate cardiac output can severely limit delivery. Conversely, increased flow can partially compensate for reduced oxygen content, as seen in conditions like anemia. Understanding oxygen delivery, not just oxygen saturation, is critical when managing critically ill patients. There are three primary mechanisms to increase oxygen delivery. You can increase blood flow by raising total oxygen delivery per minute. You can increase oxygen extraction by allowing tissues to remove more oxygen from each unit of blood. And you could shift the hemoglobin oxygen dissociation curve to the right. I know everyone's favorite thing, but this facilitates oxygen unloading. And these mechanisms often operate simultaneously during exercise and in illness. This quantifies the impact of blood flow on oxygen delivery. At rest, cardiac output, 5 liters per minute, delivers approximately 1,000 milliliters of oxygen per minute to the tissues. During intense exercise, cardiac output can raise up to 20 liters per minute, increasing oxygen delivery to up to 4,000 milliliters of oxygen per minute, even without changes in oxygen content. This highlights why cardiac output is the dominant determinant of oxygen delivery. Increased oxygen extraction occurs when tissues remove a greater fraction of delivered oxygen, lowering venous oxygen saturation. This is reflected as a steeper decline along the oxygen hemoglobin dissociation curve. Clinically, elevated extraction, as seen in shock, anemia, and high intensity exercise. There is, however, a finite limit to extraction beyond which tissue hypoxia develops unless flow rate increases. And this is showing normal, and this is showing increased extraction rates. A rightward shift, as seen here, of the hemoglobin oxygen dissociation curve reduces hemoglobin's affinity for oxygen binding strength, promoting oxygen to unbind or unload at the tissue level. This shift is induced by increased hydrogen ions or an acidic pH, carbon dioxide being increased, temperature being increased, and increased 2,3-BPG. And remember, 2,3-BPG is 2,3-bisphosphoglycerate, and that's a critical molecule inside red blood cells that binds to hemoglobin, lowering its oxygen affinity or its binding strength, and encourages oxygen release into tissues, especially during high demand. Okay, so these conditions are all present during exercise and hypoxia. Conversely, if we're talking about a leftward shift here, a left shift enhances oxygen loading in the lungs, so it encourages oxygen to bind hemoglobin. These shifts are really essential for matching oxygen delivery to oxygen demand. Relooking at the key modulators of hemoglobin's affinity for oxygen, a rightward shift occurs with increased hydrogen ions or low pH, increased carbon dioxide, increased temperature, and increased 2,3-bisphosphoglycerate or 2,3-BPG. Functionally, this means that for any given partial pressure of oxygen, hemoglobin holds onto less oxygen, facilitating unloading at the tissue level. These conditions are exactly what we see in metabolically active tissue particularly exercising muscle and chronically hypoxic states, making this shift a physiologic adaptation. Here we contrast with what happens in the lungs versus the tissues. In peripheral tissues, elevated CO2 and hydrogen ions shift the curve to the right, maintaining the PO2 gradient and promoting oxygen release. In the lungs, carbon dioxide is eliminated. pH rises and the curve shifts to the left. This increases oxygen's affinity or hemoglobin's affinity for oxygen, and it encourages maximum hemoglobin loading. This coordinated shifting is key in being efficient, and it allows for hemoglobin to act as a dynamic oxygen transporter rather than just a static carrier. This figure is showing that oxygen utilization by tissues is tightly linked to mitochondrial metabolism, not just oxygen availability. As intracellular oxygen falls, oxygen consumption remains stable until a critical threshold is reached. Only when oxygen delivery becomes severely limited does ATP production fall. Clinically, this explains why hypoxia may initially be asymptomatic and why sudden decompensation can occur once our compensatory mechanisms are exhausted. And this is rate of oxygen use. This would be normal. This would be less, and this would be more. And this is showing our kind of intracellular oxygenation levels. When we come back, we're going to look at a key component of respiratory physiology, which is VQ mismatch.